Good morning, everyone, and welcome to our webinar on pain management in partnership with St George Hospital. My name is Bertha Harvey, and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community. We also extend that respect to any Aboriginal colleagues who may be joining us today. I would now like to introduce our speakers today. So first up, we'll have Rodney Allen, who's a nurse practitioner at the Pain Management Unit at St George Hospital, Dr. Peter Cox, who's the Director of the Pain Management Unit at St George Hospital, and lastly, we'll have Dr. Martina Gleeson, who will do a health pathways demonstration. So over to you, Rodney.
Good morning, everyone. Thanks for the opportunity to come speak to you this morning. I work with Dr. Peter Cox, who'll be following on from me this morning. So this morning, I'd like to talk about pain management, particularly from my perspective as a nurse practitioner. I'll be looking initially at the way we categorise pain, just very briefly. We'll look at comfort function goals, discussing some analgesic options and how we go about planning for discharge. I particularly want to focus in on the use of slow release opioids as we move along, and weaning plans associated with that. And lastly, we'll finish up with some chronic pain referral, which will lead into Dr. Cox's presentation. So, as I'm sure everyone's familiar, acute pain, which lasts for, by definition, less than 3 months, has a known cause and expected duration. So it's relatively straightforward to treat. Chronic pain, on the other hand, or chronic non-malignant pain, which persists for longer than that 3-month period, a bit more complex. And I guess one of the things that I want to that I come across in my day-to-day is the way the term is used. So the term flare-up is what we tend to use in relation to chronic pain that is causing more of a problem in the here and now. But often it's referred to as acute on chronic pain. And we tend to use that terminology to define a new pain. So an acute injury or surgery or that type of thing, in addition to a pre-existing chronic condition. So it's important to get that terminology right, particularly when making decisions around treatment options. Sub-acute pain, which can last up to that 3-month period from an acute cause, often has that longer healing time. The patient may have significant pain at discharge from hospital and require analgesia, often opioid analgesia, to maintain physical function. And opioid weaning is often necessary for these people once they separate from the hospital. And of course, cancer pain is its own category. It's important to set realistic expectations when managing pain. We need to consider the cause of the pain, and primarily I'll deal with patients who have undergone surgery or experienced a trauma, and look at the expected period of recovery. Not everyone recovers from their surgery or injury in a few days or a week. Some take significantly longer than that, and so they're in that acute to subacute phase without having become chronic, because it's just going to take longer for that injury to heal. It's important to remember that it is okay to have some pain. Pain is a normal response. And our goal is to reduce rather than remove the pain. So we're not aiming for zero pain, we're aiming for a reduction in pain. We're promoting function so that the patient's able to get on with their day-to-day life. We tend to rely on unidimensional pain assessment tools, which are quite subjective and don't necessarily give us a great deal of information other than pain intensity. It's important to look at when pain is present. Is it there all the time? What makes that pain more problematic for the person? What are they able to do? Ask them, and observe them. Look at what they're able to do from the moment they enter your clinic. Be observing and seeing how they function. What impact on physical function does that pain have? Are they not able to get out of bed in the morning? Can they only walk to the letterbox? Can they walk around the block? What things are they able to do? Down the bottom right there, you'll see so just a very simple functional assessment scale there, and combined with a numerical pain intensity scale can be quite helpful in making decisions around the use of analgesics. So we're all familiar with the different analgesic options that are available to us. We have simple analgesics, our non-steroidals, opioids, be it immediate or slow release, and a variety of different tricyclic antidepressants, gabapentinoids, alpha-2s like clonidine and the like. It's important when we're prescribing these that we give enough of a suitable analgesia to support that period of recovery that we're anticipating for each of our patients. We need to look at the opioid use trajectory and see that if we're expecting that they're likely to be needing these for longer than that 3-month period, we need to put some strategies in place for the ongoing management of that. And if they're not reducing over an expected period of time, consider that referral onto chronic pain management service or potentially to an addiction management service as well. I'm going to digress a little bit before we talk about analgesic stewardship and just go on a little bit about what nurse practitioners are. Some of you may not necessarily be familiar with our roles, but nurse practitioners, primarily our model of care is to work collaboratively with our medical colleagues. We perform advanced health assessments, we initiate and interpret diagnostic investigations, so we look at pathology and medical imaging. We make diagnoses, design healthcare plans in consultation with the patient, their family, and also with our medical colleagues. We prescribe medications. Nurse practitioners have a restricted PBS benefit, so allowing for inpatient prescribing only. If we prescribe outside of that, the patient doesn't get that PBS benefit. We can also make and receive referrals. And this is all done within an individualised scope of practice. So my role is to review primarily acute pain inpatients who've been seen by the acute pain service. But often they've had a patient-controlled analgesia or been on high-dose opioids or long-acting opioids. And I perform pain assessments and take analgesic histories. And really important to get in early, intervene while there's still an inpatient in order to reduce that opioid burden prior to discharge. And that's what I attempt to do, so that hopefully by the time they reach your rooms, they will be on a little bit less, if any, opioid at all. I talk to patients about their opioid use and the way to use analgesics, not just opioids, and look at those realistic expectations as well. So looking at pain reduction and using analgesia to promote function. Really important to have continuity of care and build a rapport with patients. It helps with these conversations. And over a period of time in hospital, that's something I feel I've been able to achieve. And building that confidence within people is really important. I also provide education and guidance to inpatient prescribers, often the JMOs, who are the ones that are writing up discharge prescriptions and the letters that go to you. So I try and offer some guidance there, and also develop weaning plans in concert with the patient and their team, and with these as necessary. Follow-up can be arranged. I primarily try and organise for people to just see their GPs, but patients do come back and see me either in face-to-face or as a telehealth consultation. COVID has taught us. And I also have a referral pathway directly to the chronic pain service as well. So if there's someone that's looking like their trajectory is going to persist beyond that 3-month period, that's when I'll look at referring on to the chronic pain. That's just a little bit more of the same. So moving on to talk about long-acting opioids. It's going to move. The Australian New Zealand College of Anaesthetists in 2018 put out a position statement that recommended that slow-release opioids are not recommended for the use in the management of patients with acute pain. And this was based on their knowledge that inappropriate use of slow-release opioids for treatment of acute pain conditions associated with the significant risk of respiratory depression, resulting in severe adverse events and death. In recent times, earlier this year, the opioid analgesic in acute pain clinical care standard was released. Well worth familiarising yourself with this. But basically, their recommendations are that they don't recommend the use of slow-release opioids in acute pain. And prescribing discharge medication should be done in looking at their previous 24-hour use of opioids and trying to avoid those slow-release opioids, and if needed, only for a very limited duration. And this is because anything that's modified release can't be rapidly or safely titrated, and their use is a little bit more difficult to manage. So it should be the exception, not the rule, using long-acting opioids. ANZCA added to their statement more recently by saying that they recommend avoiding routine prescription of long-acting opioids in the management of acute pain unless there's a demonstrated need, close monitoring is available, and a cessation plan is in place.
Rod, there's just a question.
Yep.
What about slow-release opioid for rib fractures?
We tend to, sometimes we do use it in the context of immediate release PCA. So we'll start the patient on a PCA, we then transition them to an oral opioid. And yes, we do start long-acting opioids for these people, knowing that they're going to have often a bit of a protracted period of healing there, and the pain of rib fractures can be significant. The key thing there, though, is to have them on a low dose for a short period of time and rely primarily on short-acting opioids, or at the very least transition to short-acting opioids as soon as that pain hits a point where it's not constantly causing a problem. So if you go back to the statement that was made here, the issue around the use of long-acting opioids, regardless of the reason for using them, is that there's a significant risk of respiratory depression. So if you've got someone that's already got a chest injury, it's a bit of a double-edged. So in one way it can be a benefit, but in others you've got to look for I don't want to, I guess, be saying we should be using long-acting opioids for an extended period of time, though our practice is that, yes, we do use them for periods, and often they might be, say, if we use something like tapentadol, they might get up to 50 or even 100 milligrams twice a day. Our goal is always to try and discharge them on no more than 50 milligrams and have them on that for, say, a week or 2 weeks at the most, with a clear plan on stopping that, knowing that the short-acting opioids are going to continue for longer. One of the problems we come across is that sometimes prescribers are a little reluctant to be giving, I guess, regular scripts for short-acting opioids, because they're going to go through those much more rapidly than they are the long-acting. That's something I guess we need to consider there. Not sure if I'd answered that satisfactorily, but yeah, look, short answer is yes, we do use them. We try and use them for as short a period as possible. Now, when we're considering the use of long-acting opioids, there's a variability in the pharmacokinetic activity of these drugs. Each person's going to respond differently, so they don't titrate well in acute pain. So you can't make rapid adjustments to the dosing, and that's part of the problem with the use of them. When you use a short-acting opioid in combination with analgesia, non-steroidal and the like, you can make more rapid adjustments and get on top of the pain much more readily. There's an increased risk of opioid-induced ventilatory impairment and also persistent postoperative use, and that's the other big risk factor there. Also, the risk of diversion, misuse and diversion. There's just a few the research into why what I've said is what I've just said, and basically they're looking at ERAS, so enhanced recovery after surgery. There may be a bit of evidence around that, so that I guess can link in a little bit with these rib fracture patients as well. But who was it? Cooper, I think it was Pedersen, went on to say that contrary to several guidelines, there's no evidence supporting long-acting opioids superiority to short-acting ones in improving functional outcomes, reducing side effects or addiction. So what the studies is telling us, which is contrary to some of the practice and even our practice to some degree, is that long-acting opioids, although they sound like they're going to be more beneficial, they actually tend not to be when you look at the population. So if we do use them, it's important to introduce them only on a temporary basis. What we find when people come into the chronic pain clinic is that they've been on long-acting opioids for often many months or years. So we need to have a plan for reducing those. Consider the use of atypical opioids. The 3 atypicals that we have at our disposal are tramadol, tapentadol, and buprenorphine. These are associated with lower rates of opioid-induced ventilatory impairment and sedation and constipation. And it's important as well to reassess your patients regularly. Look at their pain, look at the dose, make a weaning plan to reduce that down. So the routine prescribing of modified release analgesics increased risk, as is long duration prescribing as well, without having some sort of a weaning and cessation plan. And quite often long-term use of opioids starts with management of acute pain. In fact, more often than not, that's the cause. A plan that specifically or that specifies dose reductions of opioid analgesics over a defined number of days and has a discontinuation requirement is important on a specific day. And also looking at opioid analgesic therapy, stopping opioid analgesic therapy reasonably rapidly if they've only been on it for a short period of time. If they're on low doses and have only been on it for, say, up to a week, you could just stop those. If they're on larger doses, and that would be something like endone 20 milligrams, BD, Oxycontin 20 milligrams BD, or Targan 20 milligrams BD. You might want to halve that and then halve it again to reduce the likelihood of them having any sort of withdrawal, but less likely in someone who's been on that for a short period of time. One of the things that hospitals are guilty of is this just-in-case discharge prescribing, where we send people home with a box of endone, despite the fact that they haven't used anything in the previous 24 hours. And there's a lot of evidence out there that says that's not a good thing for us to be doing. I think it perhaps puts you in a difficult position as well, because they say, this is what I'm on, I need more of it. So we need to look at what patients have been using in the previous 24 hours prior to discharge, and convey that information to you, so that it gives you a bit more information to work on. We're not looking at patient-specific prescribing when we just give someone a box of endone, and we can be giving too big a dose, too many tablets, or too long a period of time. And what we do know is that, particularly in opioid-naive patients, around 4% of patients discharged from hospital continued on opioids beyond 90 days, so that 3-month period, and up to 10% of them continued for greater than a year. So if we use, this is just purely for illustrative purposes, if we use St George surgery numbers, we average just under 11,000 a year, that would mean that about 425 patients remained on opioids after 90 days following. That's something that's unacceptable. We need to work on improving that. Our referral process involves receiving a referral from yourself, but generally from GPs. We're a member of the Electronic Pain Outcomes Collaboration, or EPOC, and we provide the patient with a questionnaire which involves the DAS, the PSEC, and PCS, so depression, anxiety, stress, self-efficacy, and we ask the patients to attend a pain information session, which we have as a mandatory requirement prior to getting a multidisciplinary or individual appointment, and they'll be seen then by our pain specialists, physiotherapists, and clinical psychologists. We also run group programs, Activate, which is a high intensity program, Energize, which is a medium intensity program, Insight online program, and we also run weekly strength and mindfulness classes with our physios and psychologists for patients that have previously been assessed. It's our information brochure, and these can be distributed and provided to you if you'd like. Just information about our clinic and how to make referrals to us. And our medical staff, we've got Dr. Peter Cox, who will be following on from me, Dr. Anisa Vasic, and Dr. Prashanthi Rajapan.
Rod, just one more question. What's the wait time for referrals to the pain clinic?
Our wait time is actually very quite low. It's only a matter of 2, 3, probably at the most 4 weeks at the moment, but it's pretty quick, particularly when you compare it to most other pain units in the district and in the state, which have got 6, 8, 12 months even. So we can generally see people very quickly. The thing that slows down the consultation is patients getting their paperwork and completing all the bits and pieces. So we need them to have attended the prime session And sometimes people drag their feet coming along to that, but we won't make an appointment until they've done that. And then they'll receive either their multidisciplinary assessment or individualised appointment based on their response to their questionnaires and they receive the information. So we can generally see them pretty quickly. But it's all about self-management. So we do put a lot of the emphasis back on the patients to take some initiative there as well. This is my details, and Matthew Faye's our CNC, and our unit contact details are there as well, so we can be faxed or emailed with referrals. I won't go into about the health pathways because I know someone else is about to speak about that, but there's the pain management health pathway. It's available for you to have a look at. And I have got some references.
Someone's just put a comment in the questions and answers. It's can be tricky when they leave hospital on 2 short-acting QID. Most boxes only come in a 20, which doesn't cover a weekend.
Yeah. What I try and do is factor in weekends and factor in public holidays and those sorts of things. And as we're coming into Christmas, it's always a headache when we're discharging people at that time. So what I try and do there is negotiate with the pharmacy, the hospital pharmacy, to provide enough analgesia to get them through the weekend. I also talk to patients and say to them, while you're still an inpatient, I want you to, you're going to be discharged on this day, or this is likely to be your discharge date. Make your appointment with your GP now, and that way you've got that. You're not sort of trying to make it after you've been discharged. So if we can get people thinking that way in the lead up to discharge, length of stay in hospital is so much shorter than it ever used to be. So we send people home much faster than ever, and that's part of the problem that we sort of run into as well, is that they're not in hospital to get their pain better controlled before they're sent home. So we are sending them with more pain than we perhaps ideally would like. Yeah.
Thank you. Thanks everyone for joining this meeting at this hour. Always difficult to know exactly what to talk about, but I thought 2 issues that might be of benefit for the GP population were how to manage flare-ups of chronic pain as opposed to acute pain, and Rodney's made that distinction very well. And secondly, the question of tapering of the long-term use of opioids. And so firstly, managing pain flare-ups in chronic non-cancer pain. What's the triggering event, obviously, and is this a new pain, as Rodney pointed out, or is this an exacerbation of a pre-existing chronic pain? And it's helpful just to run through in your own mind what kind of pain this is. Is it nociceptive, which is typical somatic pain, acute pain of injury? Is it neuropathic with potential nerve injury or actual nerve injury, or is it nociplastic, which is a more recent terminology, with which you're probably aware? It's basically just defines pain that's not either of the other two, but probably involves altered nociception and but where there's no physical damage. And things that have been included in this group include fibromyalgia syndrome, irritable bowel syndrome, irritable bladder, temporomandibular joint dysfunction, a number of conditions that seem to sometimes go together. You can probably include chronic fatigue in there as well. So when you're looking at pain, a flare-up, are the patients already taking opioids? Do you think they need to take an opioid for this condition? What other factors might be contributing, particularly thinking of psychological issues and social, domestic stresses and strains that might be contributing. There are a lot of things, as you're well aware of, that can lead into an exacerbation of pain. Things like you have to consider if they're already on opioids, then is tolerance a factor? Is opioid-induced hyperalgesia a factor? This condition certainly gets a lot of airtime now. Its clinical significance is still debated to some extent, but I think most people agree that it is a reality. And that it does, it can contribute, particularly in patients who've been on opioids for a while. I used to treat drug addicts for rapid detox many years ago, and I only realised later that a lot of them displayed this in their sensitivity to pain. Central peripheral sensitization, again, terms that you'd be familiar with, that may be contributing to an exacerbation of pain. So how do you go about it? Well, there is no single strategy, and these are my opinions. They're not necessarily shared by everybody, but certainly this is what the way I would look at it. Firstly, do you need to investigate? And as I'm sure you're all well aware of whether or not you image people with, for instance, increasing back pain or neck pain or some abdominal pain. And mostly, I think the evidence suggests that immediate investigation is probably not required, that maybe a little bit down the track you might, but if they're not improving. Non-drug measures, well, as I mentioned, we are talking about a biopsychosocial phenomenon here, namely chronic non-malignant pain, and there may be a number of issues that are contributing to the type of pain that you're observing. I think it's really important that you perhaps, as a reflection of the acuteness of this issue, that you see patients perhaps a little more frequently, whether it's in person or by phone, telehealth, than you would normally while they're going through this episode, that you communicate what your thoughts are, and also that you offer reassurance. Mostly we preach that increasing pain doesn't necessarily mean increasing pathology. It may do, but in a lot of cases it's not significant pathology. We encourage people to be active. We try not to use the word exercise because people have preconceived notions of what that means, and they say, oh, I can't exercise. So we just say activity, which can mean anything as simple as walking to the front gate and back. It's important to address any sleep issues that might arise through this, and the temptation, of course, is to use benzodiazepines, but we try to avoid that if possible. There are a number of other agents which could fit in here, things like melatonin, obviously, or perhaps a tricyclic antidepressant. My particular favourite's nortriptyline, which in my experience has fewer side effects than amitriptyline. Other non-opioids like the gabapentinoids, which may have a sedative effect, so a small dose. When I say a small dose, I mean starting at 25 milligrams of pregabalin at night and increasing the dose very slowly, like every few days as needed, or 100 milligrams of gabapentin, for example. And then, of course, you've got opioids, and opioids may be useful in this population for a very short period, as Rodney emphasised, in much the same way as they are in the acute pain setting. And generally speaking, my recommendation is to use short-acting agents for the reasons that Rodney suggested, and also because, well, particularly because you can titrate them more readily, and they're not in the body for as long. There's this concept of opioid load or burden, which seems to be related, the longer the drug is in the system, seems to be related to the development of opioid-induced hyperalgesia. And whilst that's debated, I think it's a reasonable premise, and therefore my attitude is to avoid the slow release agents as far as possible and use short-acting agents, so that there are periods of time where there's less or no opioid in the system. Look, that's a very quick sort of rundown of how I would manage a chronic pain flare-up. If there are no questions, I'll move straight on. Before I talk about tapering, I just wanted to remind people, sorry, this is a bit of a fuzzy slide, but the opioid calculator is an app put out by the Faculty of Pain Medicine and College of Anaesthetists. It's quite a useful means of calculating different opioid doses, particularly in morphine equivalents. So tapering of long-term opioids, what are the issues? Well, the first question, I guess, is when do you consider it? And I'm partially answering it there by saying, well, one of the first things that is talked about is the risk of mortality. When you get over a dose of 90 morphine equivalents per day, there's 7 times greater risk of mortality compared to no opioids. In terms of when it's an issue, one of the things that might indicate a problem, and particularly of opioid use disorder, are the presence of what I've called there the 4 Cs: obvious craving, strong compulsion to use, demanding prescriptions, continuing use despite the presence of side effects, and where individual dosage is out of control. We work on a figure of 90 morphine equivalents per day, but that obviously may vary from person to person, as Rod pointed out. Other questions which I will cover, is it harmful to taper? Well, yes, it can be. Who should be tapered? Who should do it? How do you do it? And is it effective? So in terms of comparison doses, 90 morphine equivalents is roughly the same as oxycodone, 60 milligrams. So that's, you can work it out, tapentadol, tramadol, and a fentanyl patch. Very low dose fentanyl really is certainly a substantial amount of morphine. You multiply the size of the patch by roughly 3 to get get the morphine equivalents. So a 12 fentanyl patch is getting up towards 40 morphine equivalents per day. In terms of your thought processes, do the benefits outweigh the risks? Obviously, that's always a big question. GPs have the advantage of knowing their patients generally, and you can feel confident or otherwise that this whatever they're on is appropriate. There's in one of the indicators is that there's no improvement or no significant improvement in function, and again, you can judge that by your knowledge of the patient. Is their analgesia effective? If it's not, maybe it's a sign of tolerance. It may be a sign of opioid-induced hyperalgesia. The question of contracts always comes up. I don't make I don't prescribe the opioid, but I don't push for people to have a contract. If you feel happier having a contract with a patient, then I think that's a reasonable thing to do. And you can bring it out if the discussion around tapering takes place. Some people will deny their side effects because they want to stay on the opioids. In that case, it may be helpful to talk to a family member. I've mentioned opioid use disorder and the 4 Cs. Nowadays, we've got SafeScript, which should be helpful to an extent. Urine testing, again, is one of those tried and tested methods. If you suspect diversion, then certainly requesting a urine test is a good idea. Who should do it? Well, almost always the GP, sometimes in collaboration with an addiction specialist or a pain specialist, and always, always happy at our clinic. My colleagues and I are always happy to discuss any tapering strategy. So please always feel free to ring us. So how do you go about it? There's no strategy, again, like managing flare-ups. There's no particular thing, but it's important to try and be pragmatic, try and be common sensed about it. Don't be threatening. Try not to be judgmental. Easy to say. Collaboration, of course, is terribly important. So the patient understands where you're going. A time frame obviously is important. My advice is always to taper slowly enough so that you try to avoid withdrawal. Withdrawal is generally considered not life-threatening, but it's very unpleasant. So taper slowly enough so that you minimize withdrawal. Whether you're using a slow release or an immediate release opioid, I don't change the drug. Some people suggest that you should convert all their slow release and immediate release into slow release and reduce accordingly. I would probably go the other way and convert to immediate release, but I wouldn't be giving them the full opioid burden that they may have started with. Remember that tolerance will disappear after a few days to weeks. Can take a while, but it can be as quick as a few days. And therefore, if your patient then goes and uses what they were using before, there's a strong risk of overdose. prescribing some naloxone may be a sensible thing to do at the start of the taper. There's always the risk that some people who are desperate and who are not coping may seek to purchase drugs illegally or use somebody else's drugs in the house. I guess you've always got the potential that a patient might stop coming to you if they don't like what you're doing. So seeing them as often as you can and being collaborative and compassionate as much as you can is obviously important. Avoid any rapid forced tapering. I'd strongly advise this unless they're clearly diverting or you think they're at risk of serious side effects by continuing at the same level. But generally, I have heard of some situations where patients have been virtually cut off, like completely. I don't believe that's a safe strategy, and I think you should do it in a much slower fashion, particularly if they've been on opioids for years. You've got to get them down slowly. You've got to get them used to the idea. This repeats some of the things that I've already talked about. Try and avoid it becoming like a forced punitive action on the patient. The trick is to get their compliance and their agreement that it's a good idea. So you spend a little bit of time telling them what the risks of continuing on this level are. Now you may not be aiming at zero opioid. You might be just aiming to reduce it, and some people will suggest around 50 morphine equivalents, so roughly 30 milligrams of oxycodone a day, and that's a reasonable thing to aim for, perhaps for a period of time, plateau on that level, and then move further from there, depending on what other strategies you can bring to bear in terms of managing their pain. There are so-called legacy patients who you inherit from other people who might come to you on big doses, and the other GP is retired, or whoever was prescribing, whether it was a pain specialist, has retired, and you get asked to take over the prescription. These are a difficult group because they're used to just getting what they want, but the same principles apply, and you might just need a little bit longer to talk to somebody like that. So in broad terms, the longer they've been on an opioid and the higher the dose, the longer your reduction is likely to take. And be patient. If the patient is strongly in favour of tapering, then obviously that will influence how quickly you can do it. Try to look after their potential for withdrawal if that's the case. And in some patients, there are suggestions that buprenorphine or Temgesic sublingual may be a useful way of going about a moderately quick taper. And I know there are people out there who've got experience of that. The other drug that's becoming thought about in terms of transition And a taper is Suboxone, which is buprenorphine and naloxone, normally reserved for opioid use disorder and substitution therapy, but there may be a role for it in chronic pain patients, in terms of providing analgesia as well as minimizing opioid use disorder. And I've mentioned naloxone. So in terms of a recipe, there's no magic recipe, but roughly 10% per month if they've been using for over a year. And obviously you need to communicate this to the patient so that they've got expectations of what is going to happen. Sometimes that's too quick, I have to say, in my observation, and certainly for those who've been on it for less than a year, it may be too quick as well. Much easier if they're not using opioids every day. You just perhaps set a number of tablets that they can use in a week and gradually reduce it. Slow down if you need to. Increasing pain during taper is not uncommon. Different factors that might be contributing are just the nature of their chronic pain, that it fluctuates, increasing stress and depression, anxiety, the unmasking of opioid-induced hyperalgesia as they gradually withdraw. And so it's important to try and minimize any withdrawal. And finally, is tapering effective? Look, I think it is. It can be a slow process, but a number of people get there. If they're prepared to stay the course, they get there. Whether it's a reduced dose, the number of people who come back and see me and say, I feel so much clearer, I'm a different person, whether they've stopped completely or whether they've just cut down significantly. There's always the risk of dropout, of course, but the evidence would suggest that pain, chronic pain, is probably no worse, and in some cases is improved. In some cases it's masked because of the opioid-induced hyperalgesia, which just seems to perpetuate the pain. Function is often improved and they have a better quality of life. They think more clearly, they have fewer side effects, they're not as drowsy, less constipation, etc. Restoring their sensitivity to pain may take days to weeks or longer, but be aware of the risk of rapid return of opioid receptor sensitivity in as little as a week, and therefore discourage the use of the same sort of doses that they were on previously, because that's where problems develop. And that's where I stop.
One slide today for participants, because we've learned a whole lot today, but remembering it is sometimes a challenge, so it's good to have a resource to refer to. So here's your login details for Southeastern Sydney Health Pathways, and that pathway area covers Prince of Wales, St George, Sutherland and St Vincent's and Sydney Children's Hospital footprints. We've got a number of pain pathways available for you, including chronic pain and complex regional pain syndrome, medications in chronic pain, neuropathic pain, and also the request pages, which you probably think of as referral pages, which is how to get the details of that clinic that was talked about earlier, or the clinic for your local area if you're not in the St George footprint.
And lastly, on that slide, we also have our email address that's available for you. If you have any feedback on any of the pathways or any requests for us to develop pathways that we don't yet have, then we'd really be very happy for you to contact our team and reach out. We try to be very responsive. We've just hit 500 pathways in the last week, so we're very proud of that work. And if you haven't looked at health pathways recently, you might be surprised to find how many more pathways there are available now.
Thank you again to Dr. Cox and Rodney, Dr. Gleason and Kylie for helping us today with the presentation. And please join us for Tuesday, the 9th of November, as this will be the last session for St. George for 2022. Thank you and have a good day.